Hi, good afternoon, everyone. Welcome to this week's DDU teaching. It's the last one for the academic year of 2019. We'll just go through a few cases for sort of half an hour and 45 minutes. And I'd like to start the first couple with some work that I've been trying to do, talking about how to fit echo into the clinical management of patients who are critically ill, and in particular, trying to look at this combination that we've got between the clinical information and the so maybe some of the minimally invasive monitoring devices that we have. So I'll just go through two cases and I'll ask you guys to report some of the echoes, but I'll talk a little bit about some of the management decisions and why I came up with decisions that we had. So we'll start with this. This is a 50-year-old man who came into our emergency department not well. He was breathless, he was short of breath, he was hypertensive, and he had some acute renal failure. Didn't have a significant past medical history other than some alcohol abuse, and didn't take any other medications. But he had a gas that was showing some significant respiratory components to his breathlessness, and he had low saturation, and he had was hypoxic. Of note, though, his lactate wasn't super raised at that time, and his bicarb wasn't out of order. He was on a significant amount of noradrenaline when he came in sort of the region of, high teens of mics per min of noradrenaline. And this was his observations that we had. So he was in some form of supraventricular tachyarrhythmia. There was significant hypotension despite the noradrenaline, which was, as I said, around about the 15 to 20 mics per min range. CVP was raised and he was hypoxic. And this led, I guess we had a broad differential of what the potential causes could be for this guy's hypoxia and hypotension. He certainly had some shortness of breath. There was certainly some changes on the chest X-ray that could be consistent with a pneumonia, and the ideas of everything from septic cardiomyopathy through to a cardiogenic shock were in the differential. So bearing that in mind, why don't we start off with the first echo image? Why don't we start? Lewis, I've got you sort of up on the screen as the first person. Do you want to just take us through some of these images as we would do it for an exam? In the DDU exam, it would be along that idea of a short stem, some clinical information, and then patient being in shock for some reason, and then this picture. So take us through.
Okay, so the obvious abnormality is an effusion. The location of that effusion is difficult to characterize.
It's definitely behind the aorta. Sorry if it's not clear on your machine. Is it coming through okay? You're seeing it's not too...
Yeah, the frame rate is very slow, but I can see that there's that large effusion which appears to be behind the aorta, so it would be pleural. I can't even really make out the left ventricular contraction, but the left ventricle appears to be dilated. The right ventricle is prominent.
Yeah.
And I'm going to say that the left ventricle appears to be reduced globally.
Let me take you through things. I'm sorry it doesn't come up super well up there. So I guess it's important, the way you're promoting it again for the discussion is very much in a systematic approach. You're starting sort of in the bottom left and sort of working your way up and round. And again, it doesn't really matter how you do it as long as it's in a systematic manner and it's quick and effective. And that's certainly where you're at. So what we can see here, I guess, would be a large pleural effusion. I think this pleural effusion is at least among the sort of 7.5 centimeter range. I think it'd be extremely unusual to get a pericardial effusion of that size, and certainly to be loculated, because you can't see anything anteriorly up at the top above the RV. So I think there'll be, even though I know the frame rate's dodgy, there are still some signs that maybe this would still be a pleural effusion if it's tricky to see if it's in front of or behind the aorta, because I think if you've got something that big, it wouldn't probably be loculated and couldn't get that big if it was a pleural effusion, would be my only comment. So, and it looks clear, so it could look like a transudate. The LV, absolutely, as you said, is dilated. It looks to be sort of greater than 6 centimeters there. And we've got severe systolic dysfunction, likely to be a chronic component to it because the left atrium is dilated. And we've likely got a reduced cardiac output because the mitral valve is not opening a huge way and doesn't appear to be horribly thickened that might prevent its opening for other reasons. Might be some regional wall motion abnormalities there. So you've got your infraseptal, your anteroseptal and infralateral walls, and the septal wall isn't moving as well as the lateral wall, but there's no great segment there that's thickening beautifully. And as you said, the RV is enlarged. It doesn't look like it's functioning normally. Is that coming up any better for you, or shall I just keep?
Yes.
Yeah, cool.
Yeah, that's better. Yeah.
So tell me a bit more about the LV there.
So now I can see the lack of thickening
Nice.
of the anteroseptal segments. The inferolateral wall appears reduced as well. Just
So
waiting
ventricle
for
coronary artery territory that might be causing some of this. What would you think?
so the LAD would supply the anteroseptal worse moving wall.
Yeah, I think it's fair
It's
enough.
possible it could be a left main with a left dominant, because that inferolateral wall is also not moving normally, although it is thickened.
Yeah, nice comment. And I guess in the setting of this tachyarrhythmia, again, don't forget in the exams to look at the heart rate. The tachyarrhythmia could also be playing a role into this, and that LV will not be filling properly, which makes it, just complicates the picture a bit further. I think saying if you've got an abnormality in one plane, you've got to back it up in another. And here in our short axis, exactly right, that whole of that sort of anterior section, or the area that be supplied by the LAD, doesn't look like it's contracting well. And you've got akinesis in the, I think it's probably the anterior, the anteroseptal and infraseptal wall. And the rest of the walls are hypokinetic, and again, severe systolic dysfunction. Just in the meaning of time, we'll just sort of flick through this case, because obviously I think you'll see the same answers in other areas. Of note in this image would be the raised left atrial pressure with that interatrial septum being pushed over to the right, and the color Doppler. Why don't we have a look at this? Harvey Bay, how are you feeling about having a crack at this one? So what am I trying to show with these pictures?
Right, so epical four-chamber view showing heart is tachycardic, probably in sinus rhythm, globally reduced contractility, and color Doppler showing a turbulent, well, I mean, I can't see the color scale, but it's showing turbulent regurgitant jet with some aliasing. Yeah,
so I don't have it. I'll say that it's appropriate. It's around about 65.
Yeah, and probably a little bit eccentric, so likely to be severe.
Yeah.
MR.
Yeah.
And with an overall clinical picture is consistent with ischemic cardiomyopathy, given the previous regional wall motion abnormalities fitting with the coronary territory, and probably some scarring in the anteroseptal wall.
Very nice. And so for the color Doppler, you said you thought it was severe, but for the color Doppler, it's normally 40% or greater for severe with the color Doppler, and I reckon that's some 40%. So why are you calling it severe?
Looks like it's eccentric and hugging the wall.
Yeah.
The LA.
And so what does that do to the color Doppler? Give me the buzzword.
It's aliasing, isn't it?
No. Because if it's eccentric, it means that it sort of hugs the wall and it gets pulled over into the wall, and that yeah, nice, excellent. So the Coanda effect means you don't get a lot of color Doppler, because the sort of the turbulent flow is, instead of turbulence, it's sort of hugs and sticks to the wall. So it's more sort of kinetic energy rather than I don't know, chaotic energy. I think it's something like that. Excellent. And what am I trying to show up here? So what's this image up here? If you can see the pulse wave Doppler, it's sitting there behind the atria. So what's this?
So that's the pulmonary venous inflow. Trying to estimate the flow reversals. I'm just trying to look at the. Oh, you've got me there. So if you've got, I can't see the cursor there, but I'm assuming it's in the pulmonary venous inflow.
Yeah, it is. Yeah.
Pulse Doppler, and it's showing. Let me time it. So that's systolic.
Nice. Yeah. So systole from the beginning of the QRS to the end of the T wave. What should we be seeing here if it was normal?
If it was normal, so during ventricular systole, you would expect inflow, but there is no inflow during ventricular systole.
Yeah, nice. And it should be greater than the flow during diastole. So we should, I don't know if you can see my cursor, but we should be seeing the systole greater than the diastolic flow.
Yeah.
And I think if you're in the exams, you're more than welcome to bag out the person's imaging, I think, because I reckon with this imaging, it's not perfectly done with Doppler. I should have had that baseline lower, and I should have probably only had about 3 or 4 cardiac cycles, and that would have shown it much better. So, you know, baseline lower, scale maybe could be less as well. So what I'm interested, filling the screen, I've probably got my gain set about right, but I could have sort of had better clarity with that picture.
So I understood the baseline and scale. So why the cardiac cycles?
Just so you've got, because I've got 1, 2, 3, 4, 5, 6, 7, 8 sort of 8 peaks in there. And if I'm really interested, what I'm really interested is trying to figure out if that S wave is greater than the D wave or not, and looking at my A wave reversal. And in that case, I should have what I'm interested in filling the screen. Because at the moment, what I'm interested in is sort of only taking up about 10% of the screen, where it should take up the whole thing. So I should have been decreasing my sweep speed so that, increasing the sweep speed so that so I've only had 3 cardiac cycles in there. And so I'd be able to see the morphology of the Doppler profile a little bit clearer.
Sure.
All right, and then we've got a bit of tricuspid regurgitation here. It's getting up to be greater than 2.8. So all pointing towards increased left atrial pressure. And so for the first thing for me is if we've got raised left atrial pressure, that's probably coming from there's increased left ventricle end diastolic pressure. And that would significantly influence me about giving this guy fluid. If I give this guy fluid, I'm pretty sure it's just going to end up in his lungs. So I do not think that this guy would be fluid responsive. I would not be giving this guy fluid, and I would be looking for some form of catecholamine support for this guy. And I guess I might just do a little bit of talk about what happened with this guy, because I think it's really fascinating, and I'm certainly not going to take credit for all of it. So I'm a big fan of using these devices. So it's either this is a Vigileo from Edwards, or you can use the Pico, but using some form of patient calibrated minimally invasive cardiac output monitor. And that means that they're not perfect. They cannot be taken in isolation. And I certainly know that's the argument about some of my colleagues who don't like to use these. Because if the example would be, let's take stroke volume variation. So this guy here has got a stroke volume variation of 15, which suggests it's greater than 13. This very nice Edwards monitor, it gives you little numbers. If it's green, it means it's okay. If it's yellow, it means that you should start, doing stuff. And if it's red, it means it's severely abnormal. And if you follow the protocol, everything will be perfect. It's sort of sometimes how it's sold. And obviously it's not like that, as I'm sure you're aware. A stroke volume variation of 15 here with someone who's got this tachycardia that may be a tachyarrhythmia and who's significantly in cardiogenic shock and who was very cool peripherally, I'm going to take a lot of that with a pinch of salt. And then with the echo, with the raised left atrial pressure, I would be ignoring this number in entirety. I would not pay any attention to it whatsoever. What is useful though is with the transpulmonary thermodilution and then being in some form of sinus rhythm is that I would trust the cardiac index and the cardiac output, and I'll check it against my echo. And it did sort of match up. So I can use this as a kind of continuous monitoring device. That means I don't have to do an echo every 5 minutes. And then with the CVP in there, and I think we can start working out some of the SBRI. I don't think that number's perfect, but it kind of matches up with clinical stuff. It matches with the lactate starting to go up to 2.5, and the fact that this patient is then becoming more acidotic. The bicarb is now down at 19. The base excess is reducing down. And this was all pointing to me to an idea that we are dealing with a cardiogenic shock. We got a terrible cardiac output with this guy on noradrenaline. And if anything, the noradrenaline is maybe not being this guy's friend, because as well as causing worsening sort of peripheral vasoconstriction when he's already constricted down, it's also providing a fluid bolus to his right ventricle, because it's a venoconstrictive effect. And then it's also causing some pulmonary venoconstrictive effect. And we know that this guy's right ventricle is not good as well. So we pretty quickly changed this guy from a sort of the vasopressin, sort of a peripheral vasoconstrictor, and put him over onto, we actually chose levosimendan in this guy. But I think there's arguments there for adrenaline, there's arguments for dobutamine. I didn't choose those because of the tachycardia, and I thought we were dealing with a tachyarrhythmia, and I stuck him on levo and amiodarone. And I think there'll probably be, we've got, how many intensivists have we got on the line? We've probably got 6 intensivists online, and we'll probably get 10 different opinions, I imagine, over what category means and stuff. And I don't think any of us have any decent evidence to support that. Just in the meaning of time, we could probably talk about that for a while, but just in the meaning of time, I just want to show you what happened next, because I think that's where the interest lies. So in summary, so far, I had a guy who was becoming acidotic, acute renal failure, cardiogenic component to it. I stuck him on a inotrope with some amiodarone to slow him down to try and help his systolic and diastolic function. And obviously the LV was bad. The good news is that it was sort of tachyarrhythmia. I got him back into sinus rhythm, and he was going a lot slower. I thought that would be filling his heart well. He was still hypotensive, but the hypoxia was a little bit better, but that was on a lot of ventilatory support. And I got him to this when I handed him over to the next intensivist the next day. And I thought I was doing okay, 24 hours down the track. So I've now got a cardiac output that's increased by about 30% to, say, 4 liters a minute. His peripheral vasoconstriction is not perfect, but it's better. As I said, CVP has come down a little bit because his heart's maybe working a bit better, and the stroke volume variation is sorted out. I may have actually taken this photo a little worse, that there was still significant peripheral vasoconstriction at this stage. And I handed him over to the next intensivist he was still getting a little bit of NORAD. He was just finishing off the course of levosimendan, and he was still pretty unwell with significantly high lactase and things. And what my next colleague did, which I thought was extraordinary, is he then chose to stick this guy with the SVRI that was more like, sort of 3,000 at that stage. He then stuck this guy on GTN, and chose GTN because this guy had a relatively normal blood pressure with the cardiogenic shock, and he still had significant peripheral vasoconstriction. And he chucked this guy on GTN, which I thought was a pretty stonkingly brave move, in my opinion. But this guy, within 5 hours, had this kind of profile, and he was off all support at all, including the GTN. And he now had a very normal SVRI. His cardiac output was 6, and the guy's lactate was cleared, and the acidosis has settled down. And I just thought it was a really elegant way of trying to use echo, the observations, as well as these minimally invasive cardiac output monitoring devices to try and manage these patients. And this guy did really, really well. And, his acute renal failure and everything settled down. And 3 days later, he was off the ventilator and ready to go for having his angiogram, figuring out whether he had sort of chronic ischemic heart disease on top of some of the potential infective processes. So I don't know if there are any comments on that, but I thought it was pretty amazing. I thought it was a good example of use of how to combine with the clinical environment and the invasive devices.
Sam, could I make a comment there? So, presuming that conservative fluid management was continued and didn't get additional fluid, it's interesting to note that the SVV has actually come down.
Yeah, totally. And that was without any fluids. So we didn't dialyze and we didn't give any fluids.
Indicator of the fact that probably, so this monitor does not time the stroke volume variation to the respiratory cycle, positive or negative pressure ventilation. So it's actually a failing ventricle versus paradoxus that shows up as stroke volume variation.
Oh, what a great comment. Yeah, absolutely. It could be, I don't think they're linking with the ventilator, and absolutely they're not going to be doing it. Yeah.
Yeah.
It's very nice. And when he slowed him down, the stroke volume variation changed dramatically.
Yeah. Slowed him down and reduced the preload and afterload with the GTN. The ventricle's functioning better.
Yeah.
And so paradoxus is going away, I think.
I think that's a great comment, and I just, and maybe I'm preaching to the choir here, but I think that just because that one sort of parameter has got huge problems when a patient's sick, it doesn't mean that we should be throwing away the baby with the bathwater, so to speak. No. I think there's still some useful information that you can glean from these machines, as long as you're linking the data with echo and your clinical acumen to make sure that they all link together.
Yeah, I always try and use echo estimated LVO TVTI to calibrate the stroke volume that this is measuring.
Yeah.
And between the two of them, they should be, close to each other. And I don't know, want to take your opinion. Do you always use volume view to calibrate into a transfer thermal dilution and calibrate?
Yeah, it's the only one that we have. It's just because Yeah, I think we sort of stuck with some Edwards material, and I like them. I think they look pretty. It's got a nice picture. I don't feel
Well, I
strongly
mean, we
about
use
whether we use Pico with it.
this is the only one that we have, but we don't calibrate it to the patient routinely using the transpulmonary thermodilution.
So what do you use? Are you using flow tracks, did you say? Or
Yeah.
yeah, so I think we got some pretty good evidence that flow tracks are calibrated against about, it's not a small number, but it's about 1,000 people who are undergoing, particularly the newer versions. It's against people who are having abdominal surgery.
Okay.
So these guys are sick guys, sort of ASA 2, 3, the people who are undergoing anesthesia. They're not calibrated for the critically ill. And the data that I've got, that's, again, not small numbers of patients, but not huge, and predominantly single center studies, but that absolutely would suggest that when a patient is vasodilated or vasoconstricted with either cardiogenic or septic shock, which is kind of the patients that I'm most interested in, they're not very good compared to pulmonary artery catheters as the reference standard. And then taking a step further, they're also only validated, I guess, within the first 24 hours of a patient being critically ill. And the longer you have the flow tracks in, the further you get away from when they were put in, the less accurate they become with the flow track, because it's just calibrated for, a different subset of patients. And that's why I think these calibrated devices, which is the transpulmonary thermodilution, are so important, because it calibrates it to the patient, so the patient becomes their own control. And I think, and again, although there's no significant data, the guys, the Frenchies who use this a lot, they would suggest that you need to calibrate these at least 3 times a day to get the biggest bang for your buck. But it'd be great to have a look at, the argument that is against that is that all of these cardiac output monitoring devices are licensed as long as they were within plus or minus 30% of what the actual cardiac output is. So you can have a flow track device that can go onto the market as long as it's within plus or minus 30% for thermodilution way. So I don't know, we don't know how accurate these guys are. And what I'd love to start doing is, what I'm hopefully going to be doing this year is trying to calibrate some of these devices versus MRI. We're trying to do a bit more MRI, cardiac MR in critically ill patients who are cardiogenic shock and septic shock. And we should be able to get decent volumes and start to figure out how accurate some of these devices really are. So maybe we'll get some more data for you in a year or so. I might just do one quick case more then, just again along this line, which is a patient I picked up a few weeks ago. It is not this patient. I've stolen this patient, this view off the internet, but it gives you an idea of the patient I picked up, which is a morbidly obese man who's known to have some OSA, who had a cardiac arrest because he had Fournier's gangrene. He was getting operated on, had several operations, but one of the last operations he was having, he got given some sedation just for a dressing change, kind of lost his airway, hypoxia, and then had a cardiac arrest. Short return of spontaneous circulation, and then he was intubated. Short run of CPR for return of spontaneous circulation, got intubated, and then sent round to our unit, and he was on a significant amount of cardiorespiratory support. I picked him up a couple of days after that, and he had this kind of picture where he had significant, I felt, bibasal collapse, a big heart, and you can see down here at the bottom, I hope you can see acute renal failure that had been worsening over the last couple of days. Now, he was on, again, not insignificant amounts of cardiac support with noradrenaline, and he was on a stonking dose of respiratory support, but it was coming down, FiO2s of 0.6 and PEEPs of 14. And this guy was needing a lot of sedation to keep him down, and was starting, fighting the ventilator. And we were in that very common scenario where either you have to sort of heavily sedate and think about paralysis and mandatory ventilation, or for me, it's lightening the sedation, letting him breathe up. And if he's on a lot of support, trying something like APRV. I'm a big fan of trying, a little bit more, glorified CPAP, a little bit more pressure in the chest, and trying to wake him up a little bit. And so I elected to try the latter. And so I turned him over onto APRV, increased up the mean airway pressure a bit. I turned around and gave my usual my usual tutorial to the junior doctors and the nursing staff about APRV and thinking I was being very clever, at which point the nurse turned around and said to me, should we do something about the map of 30? And what I'd very nicely done, I guess, is I'd missed the whole point of, I think, some of the things that were shouting out to me here is that I hadn't really thought about what the cause of the acute renal failure was, or what the cause of his having a big heart was, or the fact that he'd obviously got pretty significant pulmonary hypertension. And when we look at the echo that we did, it was pretty obvious that this guy had a rip-roaring cor pulmonale going on. And here we've got a huge right ventricle. The function is terrible. The interventricle septum is significantly pushed over into the left ventricle. And what I'd done by putting him on APRV and increasing up his intrathoracic pressure was increasing his RV afterload, decreasing his preload, and giving him a cardiac arrest, almost giving him a cardiac arrest. And that's sort of when the penny dropped. And if we just compare the top two pictures are his echo that I took after I tried to kill him. And then the echo pictures down below are the ones that he had maybe a week or so prior, maybe 10 days prior. And I think this was a big learning point for me, that this guy had lots of risk factors and lots of clinical signs that potentially could have pointed me to the fact that a lot of this was RV failure. And the fact that he was deteriorating and needing more and more support from being intubated again can scream that it's not universal, but it could be the right ventricle, and we need to go and look at these things with echo probes. And if I'd actually bothered to look at the echo that I forgot to do and even see if he'd had a previous echo, you could see that he has an at-risk right ventricle here, and potentially a lot of the support that we're trying to give for his chest could be harming his heart. And the right ventricle is becoming more and more and more of a problem for this gentleman and needed to be protected. So maybe just in the last 5 minutes, I'll try and show just the echo that I did, the transesophageal echo. And I actually wasn't doing this to try and get better pictures. It does give this beautiful picture, a toe picture of cor pulmonale with a right ventricle that is bigger than a left ventricle. I think right ventricle subjective assessment is one of the best things that we have, unfortunately, with toe. We don't have a lot of better ways of measuring it. And if you haven't seen a lot of bad right ventricles on toe, this is what it looks like. It's a great picture. And that septum, again, being pushed over into the left. And importantly, the right atrium being much bigger than the left atrium, and that interatrial septum getting pushed over into the left atrium, suggesting significantly raised right atrial pressures. I was actually doing it so that I could guide myself in with the pulmonary artery catheter. And one of the things that, again, this is just an idea, it's something that we're working on at our hospital, is this idea of the patients who've got RV failure who are seriously ill need to have some form of continuous monitoring device in there, because you can't do an echo all the time. And so, like we have the Vigileo or the Picos for the left ventricle, I think we should be using a pulmonary artery catheter for the right ventricle and looking at the pulmonary pressures. And here you can see the pulmonary pressures of 70/40. Pulmonary artery catheter being in a good spot. Again, there are other ways of sticking it in. I think when someone's got such bad TR and pulmonary hypertension, it can be really hard to float these things. And that's why you need the toe can really help floating these devices. Most often I find that it goes straight down into the IVC. So you've really got to have a good look about making sure it goes up into the pulmonary artery. And this is sort of my thoughts about how to deal with this. I'll just see if I can put that down. So I guess the thoughts I had is that once you've got the pulmonary artery catheter in it, you use that almost to decide when you need to go and do an echo, because if it's when the numbers change. And if the numbers get higher, that can mean one of two things. It can either mean that you're getting better RV function, or it can mean that you're getting worse pulmonary vasoconstriction because of a deterioration. And one's good and one's bad. And you need an echo to tell you which way to guide your therapy. And it's the same the other way, that if you have decreasing pressures, you need an echo to tell you, is that just because your RV is worsening, or is it actually because things are improving in the pulmonary vasculature? And that's obviously incredibly simplified. It's just using the pressures. And if you've got a half decent pulmonary artery catheter, you should be able to get, peripheral pulmonary vascular resistance as well as cardiac outputs. And that can help guide you then for all of the treatment that you've got to look after a right ventricle and core pulmonale, and you've got a failing right ventricle, and that's important to avoid fluid overload. Don't give them fluid. You even dialyze these guys earlier on to pull fluid off them. You've got to treat the underlying cause, of course. Give them catecholamiine support, which can be everything from milrinone to levo to dobutamine to adrenaline. I think vasopressin, if you need a peripheral vasoconstrictor rather than noradrenaline, because noradrenaline can cause that pulmonary vasoconstriction, as we said, as well as to cause some venoconstriction and give them a fluid bolus, which is never good. We've got to optimize our ventilation, avoiding, hypoxia and hypercarbia and acidosis, because those can all cause the reflex pulmonary vasoconstriction. We've got to vasodilate them with either nitric oxide, the prostacyclins, prostaglandins, and sildenafil or bosantin if you want to try some of the longer acting agents, and then mechanical support with ECMO, which I'm afraid I've never actually ever seen. So I guess it was just a bit of an example of two cases where I thought I hope just tried to demonstrate how I think we should be using these minimally invasive monitoring devices as well as echo. I don't know, are there any comments about those two cases? I think they're both quite interesting. Are there any comments about them?
Sam, just a quick question. So with Swan-Ganz used and all that, so two things I'm wondering, say, how does doing a 5-minute focused echo, just looking at RVSP and probably TAPSE, the serial measurements, compare to a Swan-Ganz measurement? I mean, is there a good comparative? Is there a consistent relationship between the?
Do you mean in terms of using the Swan-Ganz to try and estimate right ventricle systolic function?
No. To estimate the pulmonary pressures.
Yeah, I was right. How are you saying how a Swan-Ganz can estimate your right ventricle function? I think you need both of them. You can't use one in isolation. I think your echo could help you, but you need the pulmonary artery catheter for more of the continuous monitoring. So I'm not saying that, because I think your pulmonary artery catheter, all it can tell you about is cardiac output, maybe some pulmonary vascular resistance, and your pulmonary pressures.
Yeah.
But I think you've got to put that, you can't take that in isolation, just like with the left ventricle, you can't take some of those things in isolation, because you've got to look at your right ventricle function as well. Because all of those three things are all affected by your right ventricle systolic function. And if these change, you can't figure out exactly what the relevance is, because you've got to look at your right ventricle as well. That's what I was getting at.
So apart from the pulmonary vascular resistance, wouldn't you be able to get the right ventricular systolic pressure and the right ventricular systolic function from the echoes?
Yeah, but you can only get them as a snapshot. And that's what I mean, is that if you want to, this guy is obviously not going to get better in 2 seconds, and you've got to have some form of continuous monitoring device to tell you when to do the echo. And I think relying on things like acute renal failure, lactates, metabolic acidosis, LFTs going off, clinical findings, I think those are going to lack a lot of the sensitivity that we're going to require to look after someone who's so fragile. I think these right ventricles are so prone to going off, and you've got to try and pull them back from the edge as quickly as possible. And again, this is just theory. I have no evidence to back this up at all.
Yeah, and the other thought I had was, how you said increasing pulmonary pressure or decreasing pulmonary artery pressure might either reflect worsening or improvement in our systolic function and pulmonary vascular resistance. That would reflect in the systemic pressures, isn't it? If the RV or the pulmonary PVR are improving, then the systemic pressures and perfusion will improve anyway.
Yeah, sure. I guess so. So you think that's where the cardiac output would come in, do you mean?
Yeah.
Cardiac output, you see improvements in blood pressure. Yeah, absolutely. And I guess it's just maybe it's just another tool in the box. I mean, I guess by your rationale, where you're saying then you wouldn't need echo to look at these things. I just think
I'm saying you might not need pulmonary artery catheter.
Oh, not need the pulmonary vascular. Yeah, sure.
For a long time. So I'm just.
Yeah, and it's something only I'm just starting to use. I hear what you're saying. It's just I'm finding that maybe it's just, maybe I'm getting lazy. It's just knowing when to do the echoes. It's pulling the echoes out every single time. I guess what I found useful with using the pulmonary catheters recently and these RV failures is just when anything changes, it stimulates me to think, yeah, I got to go and do it. I don't think I've been stimulated to do echoes as much just by looking at someone and seeing their blood pressure improve, or them not being as peripherally vasoconstricted or something. Maybe I need to pay more attention to that. Maybe my clinical judgment's not as good as it once was.
No,
Sorry to throw a bomb into all of this, but what about just looking at the CVP?
Yeah, you reckon if the CVP changed, you reckon if the CVP went down, you're taking that to mean that your RV function was getting better, or you should go and have a look at the RV?
No, I'd say the CVP goes up, you know, then I'd get worried and maybe do an echo.
Yeah. And you don't think
Because
TR...
it seems like, I'm not criticizing you,
No, this just a conversation.
But it seems like you've put in a whole new line to get numbers that you then, when you get the numbers, you're not sure how to interpret them, so then you have to do another test.
Totally. But I'm just using those numbers to tell me when to get off my arse and go and do the test. And I think that's what I've been in trouble with.
I just used the JVP and put my hand in the front of the chest.
Is that right?
No,
You're all much better with your hands than I am. This guy weighed 250 kilograms, I've got to say, so you've got to give me a break. JVP, I can't even see it in a 40 kilogram patient. No, that's good. Guys, I'll tell you what, that's sort of been 45 minutes. There were a couple of other cases, and we'll go through those another time maybe. I might maybe call this session to an end, if that's okay. But just, we'll go through all those cases another time. But just before we go through some of the written questions, everyone, just say, thanks very much for everyone attending during the sort of 2019 teaching period. Next year will be our sort of full year of recording every session, and hope to see you then. And again, just thanks for all the support, and I hope you found them useful.